Hi, everyone. Welcome to another Wednesday VMR. I am so lucky to be discussing today with the one and only Prof. Rez coming live from a golf course.
Let's go. How are you, Sharmin?
I'm doing good. I'm super excited. Jeffrey is presenting a case today. Big shout out to Eugene and Magnus for doing scribing and teaching points. And so if you guys can get the board up, we can get started. Thanks so much, Jeffrey. I was like joking with Jeffrey before that, I'm just like chugging my coffee to be ready for a Jeffrey case, not caffeinated enough.
Sharmin, do you ever do cold coffee or only hot coffee?
I don't discriminate against coffee, so every form of coffee is acceptable to me. Yeah, I do both. I do both, mostly hot though. All right. Jeffrey, how's it going, friend?
Great. Yeah. Thanks so much for inviting me back. I'm always excited
Oh my
to be
gosh, now I'm nervous. Jeffrey, the rheumatologist, no. I
That's
should
why
be,
I'm telling you
oh
I'm
my gosh, I
chugging
should be in my
oh,
coffee.
office right now. I should not be on the golf course.
this is gonna be a relaxing case, I hope.
Jeffrey, please relax me. I need as much relaxation as I can get.
Well, you look like you're in a place that allows you to be relaxed more easily, so you got that going for
Let
you.
me, let me just share one quick golf pro because Charmaine told me to. One of the presidents, I don't know which president, they said golf is making a pleasant walk bad. It's ruining a pleasant walk. That's what golf is, and that sums it up, baby.
That's really funny. All right, Jeffrey, whenever you're ready, Professor, you want to take the first aliquot?
All right. So we have a 46-year-old woman, and she's presenting for about 10 days of fevers. So she said that initially she noticed she was having some fevers, chills, was feeling sick, a little bit of muscle soreness, and she thought that maybe that this was just COVID, some type of virus. She went to get one of those COVID tests at her local pharmacy, which was negative. Was taking some Tylenol, and then she noticed she started getting a rash that started. She wasn't sure where it started, but by the time she saw it, it was kind of already all over her trunk, her neck, her back. It was erythematous, and then eventually, over the next 2 days, it spread through almost the entirety of her body, covering all of her extremities. It went up to her face, and it spared her palms and soles. She said that the rash was it was erythematous, it was pruritic, but it was not painful. And she remembered she checked her temperature that day, and it was 101. So she went to her primary care doctor, and they thought maybe it was still some viral illness. Told her that she could take some NSAIDs, make sure to hydrate, which she did, and that it probably would go away. But if it didn't, then she should seek further care. And over the next few days, she tried doing that, but instead of it getting better, she started noticing joint pains, and this affected multiple joints, including her elbows, knees, wrists, and shoulders in a symmetric fashion. She also noticed some generalized weakness in her thighs, her shoulders, and her hips, and that this was most pronounced when she noticed it, mostly when she was going up the stairs that she's used to going up without trouble at home. It wasn't enough to prevent her from going up the stairs. She just noticed she felt weak when she was going up there. And in addition to that, she did also notice that she was having some sore throat and a non productive cough. And then right before she came to the ER, she had several episodes of non bloody vomiting. And her temperature when she checked it was 103.4. And that's the first aliquot.
Okay, hold on a second, Jeffrey. Let's rewind it 2 minutes. You said that you would relax us. But
It
by
will
the
be
way,
more
I did
relaxed.
hear. So I'll share my preliminary thoughts. There's so much info, and then Charmin, I would love for you to layer upon those thoughts. And I just want to say, like, honestly, the way that you presented this aliquot, Jeffrey, is what every physician or clinician should strive to do. Like, such a coherent story with specific examples, and just you painted the picture better than most could. So thank you for that. And I'll just, I'm going to rapid fire here to let you know what my system one thinking was based on what Jeffrey said. And I think the bigger theme is inflammation. So we know fever is the most specific marker of inflammation. And so following that thread, we say, okay, are we dealing with infection, cancer, or autoimmune? Early on in fever and inflammation, you really got to prioritize infection. But Jeffrey told us this has been going on for 10 days. And so once you get beyond, a week, I mean, viruses are still fair game, but all of a sudden, I'm starting to think atypical infection or autoimmune or malignancy. And it's really the liquid cancer that causes inflammation. But in my mind right now, and I'm a bit biased by Jeffrey, infection and then autoimmune. But once you say there's inflammation, then you got to start thinking, where is that inflammation originating? So we already said we're trying to understand why, which is infection or autoimmune, but where? And Jeffrey gave us a bunch of clues. He said muscle soreness, and then we marry that with muscle weakness, because he gave us a specific example that was hard for this patient to climb a set of stairs, and he specifically said the proximal muscle. So now all of a sudden I'm having inflammation, and I'm going beyond myalgia to a more specific term, myopathy, and maybe even a more refined term, myositis. So could we be dealing with some form of inflammatory myositis? And I don't want to, narrow to dermatomyositis, polymyositis, inclusion body myositis. I'm saying inflammatory, meaning it could still be infection leading to muscle inflammation, which triggers us to send that CK, that aldolase, to see what's going on. Then he told us that the patient's having non-bloody vomiting. And that for me is not a significant clue yet. I'm really anchoring on the overlap of inflammation, muscle weakness, muscle soreness. And really, I'm going to be curious if there is myositis. I don't want to just list a bunch of DDX. He also said there's joint pain. Joint pain either is just a bystander or it's a clue to the actual cause. But I feel like I've spoken enough. So inflammation, muscle, joint, maybe GI tract, put that to the side. And we're still refining the problem, but I promise you, there's one more. I'm so sorry, Charmaine. And then there's the rash. But maybe I can pass the mic to you to incorporate the rash, because I feel like that should be a good clue as to what's happening.
Brilliant. Never stop, Prof. Rez. I totally agree with you. I think we just like still need to define what the problem we're solving. And I feel like the DDX is like too broad with like too many potential symptoms that she's like presenting. So I think at this time it's always like a bit hard to know like what is the clue, what is the signal, what is the noise. So I really, really love how you were translating like kind of the muscle pain, like proximal to like possible myositis. She's having like bilateral, like symmetric, like big kind of like larger joint involvement as well. And I think with the rash, I'm a simple-minded human, right? I like the inside job or an outside job approach to rashes. And like when the rash is like non-painful, it makes me breathe a little bit. So I think for this patient in particular, I think we're most worried given the extent of it that is like an inside job. I always like whenever I see a rash as an internist, I pause to see like if there can be a side effect of a potential medication because those are like some of our no misdiagnoses. And could this be like an infection that is now complicated by a drug reaction, or is it like two processes going on, or and this is all like like a new diagnosis is coming to light because it's just kind of also interesting that over 10 days disease is like manifesting more, right? It just started with fevers, then the rash came, muscle pains, arthritis. So I think like sometimes like time is some of your best diagnostic friend. And so the two things that I'm debating is like whether this is all going to be a unifying diagnosis or potentially we're dealing with a disease plus a complication, like things like endocarditis, things like complications of infections, as you mentioned, Prof, I think we still need to think about, even though Jeffrey is presenting and we have a bias to like autoimmune diseases. I think the road to autoimmune diseases is to figure out if you're dealing with like any other systemic systemic infections, and mostly because like the treatment matters. If you want to give somebody infections, antibiotics is a main story with autoimmune disease. We often have to suppress the immune system, and if you've missed an infection, you can cause further damage and further problems for the patients. So I think in terms of the rash, in the world of like autoimmune disease, as you mentioned, like kind of like dermato, a lot of them have a rash as part of their manifestation of it. But again, I am still like you holding my cards close to my chest. Like we don't want to commit to a syndrome yet. Once we have a little bit more data and exam, it will help us like hopefully have a better problem representation to be able to kind of make more diagnostic progress. Prof, anything else that you would add about the rash?
Charmaine, you just shared so many pearls. Like that was brilliant. Zero to add.
All right, Jeffrey, Mike, back to you. I think Jeffrey's connection might be a little slow. He's just like, keeping us on our toes.
Yeah, I noticed Jeffrey was outside too, so I'm glad he's outside. Luckily, I have good reception here.
We need to get those vitamin Ds.
Hey, Jazz, don't make me fly over to your hometown and slap you. I'm joking. I guess that aggressive tone is not welcome at VMR. Robbie's going to scold me for that. He might kick me out. Oh, no.
Not possible. Not possible. Progress while maybe Jeffrey is like getting his connection back. Um, what do you? I think we kind of glance over the pharyngitis part of it. Does
Yeah.
that like what? And does that move a needle for you at all?
The one thing it made me think about with joint pain, muscle, fever was adult onset stills or some
Hmm.
kind of,
Oh,
autoinflammatory
sorry, I got
disorder.
disconnected.
There he is.
I got disconnected. The learning was too good. I didn't need to present anymore. It was yeah, I just wanted to highlight a couple things. Sorry, before I disconnected, just of how amazing it is that as Prof. Rez was saying, I presented so many symptoms, and that he just, out of all the different things, the thing that he highlighted was the time course, and I think that's just so amazing that he is able to hone in into like what is the most relevant to think about when you have a complex case. And then I really like the way that Charmaine was talking about the road to autoimmunity and how it's important to also think about possibilities, relevant, important possibilities. So I just wanted to highlight those things, and then I'm going to move on to the next aliquot, which is a little bit of a short aliquot. So it's her past medical history. She has hypertension. Her medications is just amlodipine 5. And to Charmaine's point, this was not started anytime recently. She's been on this medication for over a year with no changes. No surgical history. And social history. This is going to be interesting. So she doesn't smoke or use any drugs, has occasional alcohol use. She has 2 cats at home. She came back from a trip to West Africa about 2 to 3 months ago, and she took all her relevant, infectious prophylaxis before being there, and she's been on anti-malarial prophylaxis, which she's no longer taking. And most interestingly, she's a physician. And I think right before I started, I heard Papa talking about adult onset Still's disease, and she's asking us directly, like, is this lupus? Is this adult onset Still's disease? And so that's the second aliquot.
That's amazing. Just as if this was not high stake enough, let's make it a little bit more high stake. I mean, I love my fellow physicians, but sometimes like it's hard to have like be objective to yourself. So sometimes we don't make the like best patients, I have to say, for myself at least. But yeah, super interesting. Yeah, thank you so much, Jeffrey. Just I agree. Like amlodipine, like in terms of like side effects, we often think about like the lower extremity edema. Sometimes like it rarely can cause like kind of gingivitis type thing, but I don't really associate it with kind of like the rashes we think about. So most likely that's just benign and we can move past it. In terms of the social history, a couple of things. The cats, I think, like we often like think about Bartonella, the cat scratch diseases when it comes to the cat. For a pregnant lady, a woman like worry about like kind of toxo as well. Doesn't really quite match this in the script for me just yet, but is like notable. That is one thing that with the travel, it can. I think oftentimes in clinical reasoning spaces. Travel is the one thing to keep in mind, but again, I think it expands your differential. But I think the trick of it is like you want to activate it at the right time. The few things that right off the bat that I would just note is that like again, it was months ago. So even if this is related to travel, it would be something with a long incubation period. Things to like always want to make sure like HIV, getting an HIV test to make sure you're not dealing with acute HIV, or also like someone who's immunocompromised. The other ones I often think about like histo, malaria, are the other ones that to think about, and like TB is the one that also you can get it anywhere in the world. So those are like kind of like again like those infections all can have like systemic manifestation, and we still don't know the extent of like the good problem that we're trying to solve. But those are the couple of things that I would keep in mind while like trying like going and examining and getting labs. Prof, what else are you?
I love that so much, Charmin. I think for me, just addressing her question of can this be adult onset Still's disease? I would just, as a non-rheumatologist, tell her that that really ends up being a diagnosis of exclusion based on the Yamaguchi's criteria. And yeah, she could have some kind of mixed connective tissue disease for sure, but we just got to temper ourselves until we get the labs, and we might get a clue to what might be driving the underlying process. Back to you, Jeffrey.
All right, amazing. All right, so I'm gonna go to the next aliquot, which is gonna be her physical examination after she's hospitalized. And there's gonna be some interesting findings here. So first, her vitals. She's tachycardic to 120, and she's febrile to 101.4. But thankfully, her oxygen sat and her blood pressure is fine. She's not doesn't seem septic appearing. On general exam, she just seems tired. Her eyes, she has a little bit of maybe swelling periorbitally, bilaterally, but no conjunctival injection. HE and T exam, she has no ulcers in her mouth or her nose. When looking at her throat, there's mild erythema, mild pharyngeal erythema, but there's no exudate. And she maybe has some mild cervical lymphadenopathy without tenderness bilaterally. She's tachycardic, but otherwise her heart sounds are normal. Her lung exam is clear to auscultation. She's not breathing hard. Abdominal examination is normal. She does have no rash at this point, but she brings pictures of her rash. And it is a maculopapular erythematous rash covering her trunk, her back, her neck, and her extremities, sparing the palms and soles. But the interesting thing about this rash, and she brings up, is that she says that this is a malar rash on her face. So when I took a look at it, fortunately, I don't have the pictures that I can show you, but when I took a look at her face, what she describes as a malar rash is actually a rash that's kind of erythematous, like on this area of both sides, that doesn't actually go anywhere close to the nasolabial folds or even in the nose area. It's just kind of on the cheeks bilaterally. And then her MSK exam, she's got inflammatory synovitis of both of her wrists and knees symmetrically, as well as maybe some tenosynovitis of her ankles also symmetrically. And other than that, she just has a little bit of bilateral lower extremity swelling. And that's the end of her third aliquot.
This is so cool, Jeffrey. I'll just share like what jumps out to me. When you said periorbital swelling, in the context of joint pain, muscle soreness, muscle weakness, it prompted me to think of the raccoon eyes of dermatomyositis. So that's one thought I had. I'm dying to know what her CBC is going to show, because we know with the dot onset stills, you have a neutrophilia as an autoinflammatory disorder. And that rash is usually salmon colored, but it waxes and wanes. Now, with infectious mononucleosis, especially if there was antibiotic exposure, you can end up getting a reaction where you get this macular and papular rash. And so if we see a lymphocytosis, a neutrophilia, those might be very strong clues to what we are dealing with here. So for me, at least right now, I haven't made much progress. I can't tell you this, that like tick-borne diseases shouldn't, like if this was Rocky Mountain spotted fever, it would involve the hands and it wouldn't last this long. And Jeffrey painted the picture of a central fleeing or centrifugal rash, sparing the palms and soles. You have to think about syphilis. I love the idea of an HIV test. But for me, Charmin, the next steps that's going to be so helpful is going to be that CBC, specifically the diff, looking at the CK, looking at the liver enzymes. I would, in this patient, look at the UA carefully, because I'm just curious if we are having some kind of multisystemic process with a fingerprint on the kidneys. And also I know she doesn't have chest pain, but could the heart be involved as well? Not that I would send a troponin, but those are my preliminary thoughts. Back to you, Charmaine.
Yeah, I totally agree with those thoughts. And, I think the other aspect of her presentation is kind of like this, like symmetric kind of arthritis involving like kind of the bigger joints of the knee, wrist, and ankle. Oftentimes, like I think like this like poly arthritis that is involves the big joints tends to favor more. Your autoimmune diseases. Infection causes are rare, although it can happen definitely. And I think like in the most common I think is please correct me, Jeffrey, but I think it's like RA, and then like psoriatic arthritis can do it, lupus can do it. However, like I agree in terms of like kind of the rash and like it is a good story for adult onset Still's disease. And I think as we talked about, like kind of those kind of big bucket symmetric systemic infections, the other ones that also like came to my mind, that kind of like mononucleosis type, like 10 days is a long time by thinking about like your EBV, CMV. Again, not a perfect like with the it can cause like some arthralgias, but like I'm not sure if it can cause like kind of just like polyarthritis, but those are like the other ones that was like coming to my mind. All right, Jeffrey, back to you.
Amazing. I love all the thoughts and insights so far. And I guess, if I can't make this relaxing, at least I'll make it exciting for both of you guys. So we're going to go to the labs next, which is what Prof. Rez was asking for. And interestingly, so the CBC was remarkable for a leukopenia of 1.9, and she actually had a little bit of neutropenia to 1200. Her lymphocyte count was also a little bit low. So she also had an absolute lymphopenia as well. But her hemoglobin and platelet counts were both normal. And her CMP, so essentially her electrolytes were normal, but her creatinine was elevated to 1.9. And she did say that she maybe took a couple of doses of ibuprofen once or twice a day. Not enough that she would suspect that she would get an AKI, given she's a physician and she's very mindful of it. And then her AST, ALT were both normal at 42 and 31. Normal otherwise liver function tests. Protein was 6 and albumin was mildly low at 3. And her serum uric acid was checked for gout, and it was elevated at 8.5. Her ESR and CRP were elevated at 54 and 4. Her ferritin was slightly elevated, borderline at 266. And her CK was slightly elevated at 446. Urine pregnancy test was negative at this time. And her urinalysis showed 3 plus protein and 2 plus blood.
Sharmizi, I think it's your turn, yeah?
Yeah, let's sorry, one second. Um yeah, so super interesting, Prof. Raz. So we were in terms of like the CBC itself, we were thinking like, oh, oftentimes like with adult onset Still's disease, we see like and we see like a leukocytosis, and oftentimes like it's neutrophilic predominance. We got the opposite in the sense of like leukopenia and lymphopenia and neutropenia. So in general, like leukopenia, and I oftentimes like you see that in a lot of the kind of viral infections, bacterial infections. Any sepsis etiology can cause leukopenia. As Jeffrey mentioned, this doesn't sound like someone who is like septic. Autoimmune diseases like lupus, notoriously you can have you can have a suppression as well. And I think in terms of the UA, the other thing that it like really jumped out is like the proteinuria. And Prof. Rez, it reminded me of what you said for your aliquovic goes like looking for other like end organ involvements, like whether like the kidney is involved here. And with the blood and the protein and the AKI, I think we just got to think about like glomerulonephritis and thinking about like, or are we dealing with one of those disease etiologies? Whenever I think about like glomerulonephritis, I often like think about like whether it's like immune complex mediated and like anti-GBM. Again, like anti-GBM less likely in this patient. I think like one things that are really helpful is like complements. Like if this is like a complement mediated process, a lot of our infections, like HIV that we were endocarditis, all of those tend to be more like complement mediated processes. Lupus that we were thinking that I mentioned earlier, and like kind of some of the lymphomas. And I think like that's another thing that oftentimes like enters the chat is like kind of lymphomas, that they can do whatever they want to do as well. But I'm like now worried that we're like dealing with like an inflammatory multi-system disease that potentially can involve the kidney. And oftentimes when I'm thinking that, I want to I want to potentially have a renal biopsy to make sure what is the disease pathology that we're dealing with, in addition to just like make sure getting my complement levels in this case. Prof. Rez, what are your thoughts?
My thoughts is that's such a beautiful analysis. I really have zero to add. I just had this reaction when Robbie and I were discussing a case once, and we like centered on the kidney, but the kidney ended up just being like an IgA nephropathy leading to GN. So I don't want to dismiss the kidney findings. I don't think anyone would dismiss them. But the question becomes, can we get a diagnosis without biopsy? I'm not sure we can. And yeah, you know, in this sort of world that we're in, could this be an MPGN and just secondary to whatever the underlying systemic inflammatory disorder is? But yeah, I don't have anything more to add to that.
All right, I guess it's back to me, and I'm gonna add something very interesting to this next aliquot. I've been trying to think of where to add it, and I think I'm gonna do it in this next aliquot. But I'm gonna share with you some of the rheumatologic workup now, and then we're gonna add. I'm gonna add something very fascinating that happened in the middle of this course. So her ANA was checked and was positive to 1 to 640. Double stranded DNA was positive. The rest of her panel, including SSA, SSB, Smith, RNA polymerase 3, RNP, SEL70, RF, CCP, and ANCA were checked. They're all negative. Her complements were checked, and the C4 was low at 6, but the C3 was normal. She also had an SPEP that showed a very faint IgG kappa band. Her 24-hour urine protein was done, which showed 6.8 grams of proteinuria. And she had a peripheral blood smear that was unremarkable. And now I'm going to add this next piece of history that happened in the course is at this point where we were being presented with this complex patient with a bunch of different findings that we're trying to figure out what was going on. We got a second consult for a patient that had fever and arthritis. And the arthritis was also symmetric. But the interesting thing about this patient is when we had this, we're in the middle of the conversation, we somehow realized that this patient was seen by the physician that we are seeing right now several days before while she was working as a hospitalist. And it brought up to us to mind whether this could be a irrelevant thing or whether this could be a sick contact that she could have been exposed to. And that's all I'm going to reveal for now.
Wow, that's so interesting. I'll let Sharmin tackle that part of the story. But with the other part, I think you're making a very strong case for lupus because you have a very high ANA, which is sensitive marker, but you have a more specific marker, the double-stranded DNA. I'm okay with C4 just being low. And so now I'm worried about lupus nephritis. But I don't think lupus itself can explain all the findings. I'm getting more of a flavor of potentially overlapping autoimmune diseases like lupus, dermatomyositis, giving me more the frame of a mixed connective tissue disease. I'm going to leave it at that, but give the mic to Sharmin to tackle that other part.
Yeah, that is quite interesting. And I think like my Gestalt think that it might be a coincidence because I feel the reason why I say that is just kind of like that. I don't know how many days has passed since like the onset of her symptomatology. Like I would like at least like 10 to 15 days, let's say. And for her to have like a communal disease that can be passed on, oftentimes like we think about like kind of like airborne. So like the ones that I would like worry about if she has like pulmonary TB, we're not getting any flavor of that. Arthritis, like the entire presentation is rare. A lot of the like infections at this point that is like kind of more subacute like HIV, wouldn't just pass like by seeing a patient in the hospital. So I would probably think less likely that this is related to each other, and most likely it's going to be a coincidence. The one thing I would do um, just to make sure, I would probably just like put it in a chat GPT as well, just to make sure, hey, any infections that would be communal. Not that I can like think about off the top of my head, because I would think about more like viral syndromes for that, and it doesn't quite have that flavor for me. I'm excited to learn more, Jeffrey.
Yeah, amazing. I'm so excited to share this next aliquot. So essentially this next aliquot is going to be some more of the labs that she gets and then imaging. So she has testing for a lot of infectious diseases, HIV, syphilis, hepatitis serologies, mycoplasma, viral respiratory panel, rapid strep, monospot, as well as blood cultures. Those are all negative. And she has APLS labs that come back negative. So those are antiphospholipid labs like anticardiolipin, beta 2 glycoprotein, lupus anticoagulant. She has a cryoglobulin screen that was sent, which was negative. The x-rays were done of her joints, the hands, and the ankles.
Oh, I think Jeffrey, we lost you.
Just let me put out the last one. Let's go.
Oh, while Jeffrey's connection gets better, I shout out to David, because he mentioned like parvovirus, and that is like a really good one to think about here. Thanks, David. Because like yeah, with like parvo, you can get that acute symmetric arthritis, the maculopapular rash, the leukopenia, but like oftentimes I can be like pancytopenia as well. It's often just self-limited. But that is a really good thought, David. Thanks for sharing.
I'm so sorry for getting disconnected again. I think my computer is trying to tell me that this case needs to be more relaxed. So sorry, I was in the middle of that aliquot, and so I was just going over the infectious labs, which were mostly negative. And then the only addition in the rheumatologic workup being antiphospholipid labs and cryoglobulin, which was negative. And then radiographs of the joints essentially are showing synovitis because they're showing subcutaneous edema around the soft tissue of the joint spaces, including the wrists and ankles, which corroborated with our exam of the patient initially. She also had a chest x-ray that was normal and a renal ultrasound that showed no hydronephrosis. And interestingly, at this point of time now, the patient has not yet been started on steroids because we were still trying to understand what was going on. Nephrology was consulted because of the high proteinuria and the blood in the urine. And interestingly, the patient's creatinine had been downtrending and is now from 1.9 is now down to 1.3. And when we repeated the 24-hour urine protein just to make sure it wasn't just a one-time false lab, it went from 6,800 to 3,400 in one day. And that's the end of that aliquot.
Man, that is. Oh, it's you, Sharmin. Go ahead.
That is like, oh, maybe Professor, maybe we can dance together on this one. This is fascinating. So I think the question then becomes like, what disease pathology can improve without any treatment? Oftentimes, like self-limited infections or like sometimes like episodic diseases, oftentimes can have this periods of like quiescence and that they like flare up again. Um, I do like, I think like it is a good story for lupus. The question is like, can lupus have been triggered by something else? And the more I think about David's point of parvo, the more I like it as well. So I think like that's the one thing that I would consider a little bit more in terms of like infectious etiologies because it tends to be self-limited. It can improve on its own. It is passed around with like respiratory droplet. It can incubation period can be up to like kind of 20 days. That is the and maybe like and as you mentioned, maybe like the AKI wasn't part of the disease process and just a bystander, and I got damaged due to like dehydration, like hypovolemia, all of the others reasons why we get an AKI. So that's the other thing that oftentimes when people start getting better on their own, I think about like, okay, episodic diseases and also like infections that are just improving with supportive therapy. Well, what about you, Prof. Rez?
Yeah, that's great. This is a tough case because at the end of the day, you want to do less than more and try to get to a diagnosis without having to necessarily pursue a biopsy. And I'll tell you, like, I don't think, I mean, Jeffrey would be able to correct me, but I doubt that lupus nephritis would just get better with like no steroids. Like, lupus nephritis is an emergency where you have to give a gram of methylprednisolone. And sometimes you can overestimate the proteinuria in the context of an AKI because it's quite concentrated. But the 24-hour protein is quite good. I didn't catch the albumin, but it was giving me a flavor of nephrotic syndrome. So it just makes me wonder whether this was all like IgA nephropathy that was just transient and she's getting better. But what this would make me do is probably not pursue a kidney biopsy. And then honestly, talk to someone like Jeffrey and be like, can we just start steroids? Can we just start her on therapy for lupus and see what his thoughts are? Because even the leukopenia is good for lupus. The proteinuria was good. I mean, the rash can do anything. I mean, we said that the nasolabial folds were spared, so it's not like slam dunk that. But finally, I would ask someone like Jeffrey, and I would love Jeffrey to teach us, could this be like an overlap syndrome, like dermatomyositis, lupus, that was maybe triggered by some kind of infectious process?
Awesome. Yeah, so there's so many aspects of this case that were concerning about lupus, but just as Prof. Rez brought up, it's very strange that you would have lupus nephritis. Why would it self-resolve? And I think the other point I'm gonna go back to is the very first thing that Prof. Rez brought up at the very beginning of this whole case. Before we knew anything besides that there was a lot of different symptoms and this could be challenging, was that time course. Very interestingly, was relatively acute and possibly extending into the subacute course, where autoimmune diseases certainly at some point do present acutely, but usually we see them chronically. So at this point, we were considering, should we give steroids empirically, or can we watch this patient get better on their own? And so what happened is we rechecked labs. We decided to monitor this patient, and about 2 days later, her AKI resolved. So her creatinine, it didn't completely resolve, but her creatinine went down to 1.0, and her proteinuria went down to 2 grams. And then before I reveal the final diagnosis, the last hint, or I guess the last piece of the puzzle, the clue is that a test came back, and it wasn't a test that was sent on this patient. It was a test that was sent on a patient that this physician saw. And that test was positive for something that ended up being very relevant to the diagnosis at hand here.
Jeffrey, that is phenomenal. I think what I wish I could do right now is get on the computer and pull up our fever and rash schema, because that other patient you described, I think you described as having arthritis and rash and fever, correct, Jeffrey?
Yeah, actually, the other patient only had fever and arthritis with no rash.
Only fever and arthritis, got it. Yeah, I wish I could pull up that. Well, I guess that schema becomes irrelevant because there's no rash. So I think we would focus on infections that have a tropism for the joint and can wreak havoc on the patient. And it's unlikely to be bacterial. It's giving the flavor of a viral. And now the question becomes, what viruses love the joints? But I'll let Sharmin answer that question. You don't have to agree with me, Sharmin.
No, I totally no, I totally agree with you. As always, it's just a smart thing to do. And it's also 99% of the time is always true. Yeah, I think I think like we mentioned like a parvovirus, like hepatitis at times, as well, it can cause similar findings. The other ones that I would like, honestly, I feel like is a really good case for parvo. The more I think about it, I think like the other like is if we say like, oh, was this like arthritis. The one I was like want to think about is like reactive arthritis and like gonorrhea, those diseases. Again, like probably less likely in the context that we are in. So I would also like worry about more like kind of a viral etiology. And I think like parvo would be the highest on my differential, just given the symptomatology. And like kind of the fever, the rash, the leukopenia, um, and kind of like getting better on its own without any treatment. So that is like where my brain is at. I'm very curious to see what happened, Jeffrey.
Yeah, amazing. So you guys essentially nailed the diagnosis. The parvovirus B19 came back on the patient that a different patient that we were consulted in, and we sent a PCR in the blood for parvovirus B19 and the serology test for this patient. Both of them were through the roof. And very interestingly, the question at this point is, does the patient have parvovirus B19, lupus plus parvovirus B19? Is this relevant, or is this different because we have so many serologies that are positive? So I'll share that this patient was seen in follow up about 6 weeks from this case, and absolutely everything had resolved, including all of her serologies. Her complements normalized. Her ANA was still positive, but the double-stranded DNA was actually negative at that point. And so I wanted to share this case because it was so exciting. When we get taught in internal medicine about parvovirus B19, we classically get taught that it mimics rheumatoid arthritis, but is on the more acute side. So before 6 weeks, if a patient has a presentation like rheumatoid arthritis, it can be viral, and the most common identified viral infection is parvovirus B19. And then over 6 weeks, the rheumatoid arthritis goes into play. But what we don't really mention, and what I've only realized after becoming a rheumatologist, is that it can also mimic lupus and ANCA vasculitis. It's very common for this virus to cause a lot of false positives. Rheumatoid factor, even CCP, double-stranded DNA, ANCA, all of these can be false positive. And part of that is because of its ability to form immune complexes that deposits in areas like joints. So the diseases that it can acutely occur that I think they're all kind of mentioned here at one point, but to think about rheumatologic disease, but in the acute form, is it a viral infection that's able to create immune complexes and mimic it that way? Is it a medication reaction that's able to do that, like stress or serum sickness? Or is it just an overwhelming state of inflammation that you sometimes get in really bad cases of lymphoma, endocarditis? And I think in this case, what was very interesting looking back is that when I took a look at a rash again, with parvovirus, you get something called a slapped cheek rash. And what she had initially thought was a malar rash was actually just on her cheek, and it wasn't crossing or covering anywhere in the central part of her face, which was more consistent with erythema infectiosum or parvovirus B19. And I think those are all my teaching points that I had. I think you guys already covered most of the other ones that I really wanted to highlight in the beginning. So thank you so much for both of your insights and discussion on this case.
Prof Rez, what are your thoughts?
Well, I mean, just this is incredible. Like, what a case. I honestly, it was better than golf, and I mean that. I, I just have a question for Jeffrey. By the way, I think the fact that it's parvovirus, it's just not something we see often. So it's really hard to do S1 thinking and just reflexively say, oh, this is classic PARP because it's so rare. It's much easier for our brains to navigate towards lupus, something that we think about often. But my question for Jeffrey is, the fact that the antibodies were positive, does that suggest any vulnerability to developing lupus down the road? Or is this just, man, if you just screen 1,000 people with some kind of viral infection, maybe 10% of them will have positive antibody. It has nothing to do with what their risk is of lupus in the future.
Yeah, this is a great question. A question that we've talked about with our immunologists, because it's very interesting with parvovirus. So probably the concise answer is there is some increased vulnerability because there are patients who don't have lupus, but once they get their first infection of parvovirus, they have lupus for the rest of their life. Um, Most patients who get parvovirus don't end up getting lupus, but because there are patients that do that, and especially that occurs in the context of positive autoantibodies, those are patients to be a little bit more cautious of monitoring. With what we usually do is like annual visits, making sure nothing else comes in the future. But it signifies that the immune system has already a possibility of trending in that direction, that if it was a different trigger even next time, it could lend them into the lupus realm.
Wow. Yeah. Wow. This is fascinating. Jeffrey, you're awesome. Thank you so much. This is such a great case. And I'm just going to shout out David for putting parvovirus in the chat. Like, that's why VMR is amazing and why it's just so much more fun to do medicine with each other. We learn from each other. And yeah, I wasn't really thinking about parvo at all until David mentioned it. And I was like, oh, it actually does quite fit. So, it's kind of the amazingness of the brain trust here. And Jeffrey, your teaching is always so good, and I learned so much from you. So thank you for being here, and thank you for teaching us. Prof. Rez, you're the best. Thank you for letting us be part of the Gulf today. Thank you all for joining us. Big shout out to Eugene for scribing, and Magnus, to you to go do the teaching points.
Thank you so much, and thank you for an amazing discussion, an amazing case by Jeffrey, as always. We started out with a patient with a fever for 10 days, which we translated into inflammation. And we all know the eye made mnemonic, so this could be caused by infections, cancer, or autoimmune diseases. The time course in this patient prioritized infection and autoimmune diseases. Also, we saw that we need to figure out where the localization of the inflammation is, and here the muscle weakness could be a clue to that. So it could be translated into a myopathy or a myositis. So that would make us get a CK level to see if the muscle is involved. Also, the joint pain, as at this point, also in a patient with inflammation, it's important to figure out whether there are any exposures. And this patient had a cat, which should make us consider Bartonella, and also had a travel history, so we should take that into consideration as well. And it's very important to rule out infection before starting immunosuppression, which could make the syndrome worse. The patient also had a lot of different symptoms. So she had a rash and arthritis. In terms of the rash, we were thinking if this was an inside job or an outside job. In this case, it was not painful, which may point towards an inside job. We also saw that rash, together with muscle symptoms, could be combined into dermatomyositis. So that was also something we thought about. And the arthritis again points towards either autoimmune diseases like rheumatoid arthritis or lupus, Still's disease, crystal arthropathies, or infections. So with all these symptoms, we should get just a broad workup to look for systemic clues of where to go next. We then saw that the patient had leukopenia, which made us consider again lupus, but also infections can do this, like HIV or parvovirus, and also bone marrow suppression or medications. And we also saw her proteinuria and hematuria along with her AKI. So we thought about a possible glomerulonephritis, and we considered whether we should get complement levels and also consider a renal biopsy at this point. And we know that infections like endocarditis can cause GN, but also again autoimmune diseases and cancers, especially lymphoma. Her positive ANA and double-stranded DNA at this point made us also look towards lupus nephritis. But we also need to remember that in a patient with AKI, we can overestimate proteinuria. So it's also important to trend that. And we actually saw in this patient that the AKI resolved, which again could be an episodic disease, like in a flare of autoimmune diseases, or an infection that resolves by itself. The test came positive for parvovirus B19, and as Jeffrey beautifully told us all, parvovirus can mimic rheumatologic diseases and cause a lot of positive serologies. So for me, this was an extremely interesting case that I have to reflect a lot about. But thank you so much, everyone, for this amazing hour.
Brilliant, Magnus. Thank you so much for distilling down the teaching points. I also have to reflect on this case for a while. Thank you so much, Jeffrey. Really appreciate it. Prof. Rez, do you want to sign us out?
Do-do-do.
There you go. Bye, everyone.